So, now, first question for you. What is your opinion how to measure the expertise of a dermatologist doing his job with nevi and melanoma? What do you think? What is more important? Is this important, the number of malignant lesions that are correctly recognized? Yes, of course this is important, right? Definitely it's important. But don't you think that it's also this important? Yeah? The number of lesions which are ignored, you know? Because, I mean, come on. If this is my son, yeah? You see my son. He's now 21. He's not looking so beautiful like here. This is when he was 15. Now it's more ugly with acne stuff, you know. So, so if I say to my son, go to my office, because now today I'm sick, yeah, go to my office, and whatever lesion you see on the skin, say excision, yeah. Do you think you will miss a melanoma? No, of course you don't, yeah. But if of course he will excise a lot of lesions, benign lesions, which is unnecessary to excise, right? So the real expertise is measured by the number of lesions that we are saying, oh, don't worry, it's benign, you know? This is really important. So the point is, in our daily life, we have two goals, yeah? And we, as dermatologists, we are confronted with many of healthy people, you know, coming for nothing, coming because just they are afraid that something wrong can happen, you know? And our job is to say, don't worry, this is just nothing, okay? So our daily goal is, on one side, to treat sick patients, but also to save the healthy, you know, not to do anything on the healthy. The point is that we need to diagnose this melanoma, but in order to diagnose this melanoma, we have to see hundreds, but not hundreds, thousands of benign lesions. Thousands of benign lesions to catch one melanoma, okay? So this is our daily job. So now another question to you. Is this patient sick or healthy? Sick, you say sick. Well, definitely our feeling is that he's sick, but it depends on the definition of sickness. What is sickness? Having a disease. Is a nevus a disease? No, maybe not, right? Melanoma is a disease, but the nevus is not a disease. And definitely these are just multiple nevi. Our problem is that maybe one of these lesions is a melanoma. Yeah, exactly. So this patient was treated like this. So now, do you think that this patient is now sick or healthy? Definitely pretty sick. So we transformed a healthy patient into a sick one. Yeah. So, I mean, to remove nevi is not necessary. Of course, we have to remove nevi only for one reason. Only for one reason. The reason is that we cannot exclude that this lesion is a melanoma. Yeah? There is no need to remove nevi to prevent melanoma, because only one nevus out of 200,000 nevi will become a melanoma. Can you imagine? So if we have to remove 200,000 nevi to prevent one melanoma, which is obviously stupid. This is a real treatment. This was published by the group of the guys from Tübingen. You know, in Germany they are very aggressive. Yeah. So, okay. Now, in my view, expertise is measured mainly by the number of ignored benign lesions. Melanoma, and this is the good point, is easy to be diagnosed in 70–80% of cases, you know. But definitely, of course, there are some. Where is the next to be diagnosed by? Yeah, it's not appearing. So in the great majority of cases, melanoma is easy to be diagnosed clinically. Yeah, you don't need anything else than just to look at the lesion and you know what it is. But in, let's say, 20–30% of cases, we need more. We need dermoscopy. We need rules. We need clinical rules, okay? And this is what, in my view, I was learning in the last few years. Dermoscopy is not the solution of everything. We need clinical, we need dermoscopy, and we need rules, clinical and dermoscopic rules, in order to catch melanomas, okay? One of the main clinical rules that I use is the age, you know? Age for me is extremely important. I don't do, in these 3 age groups, I don't do the same things. I do different things here, I do different things here, and I do different things here, okay? So, let's start with the children. How many of you saw a melanoma in a child before puberty? Nobody, yeah. I saw maybe once or twice. So it's extremely rare, extremely rare. So I don't care about children, you know. This is the point. I don't care about children. I care about only 2 things. What? Spitz nevi and congenital nevi. That's it, you know. But not because Spitz nevi can become a melanoma, but Spitz nevi can be difficult to diagnose, and we have to know how to manage it, okay? So in children, let's make an example. Spitz nevi are not dangerous at all, okay? Before puberty, the probability that what we are looking is not a Spitz nevus but a melanoma, it's just 0. Okay, so whenever we see a lesion like this is Alessandro, 9 years old, lesion on the knee, and that's what we see. That's a Spitz, and this is for sure a Spitz. Yeah? So if we like to remove it, okay, don't worry, you can. But it's not really necessary, okay? And I can tell you, I show you this case because this was really frightening, really frightening. Can you imagine? We did a follow-up in 3 months, yeah? And this is already incredible. Look how this lesion is growing. Just 3 months, yeah? Just 3 months. But then we were brave enough to keep going 3 months and then 12 months. Wow! And we said, oh my God, this is terrible, yeah? But could it be a melanoma, this one? No, no. It's not a melanoma. This is 24 months. And this is 36 months. And then after 36 months, the father of this little child told me, "Doctor, I don't want to see your face anymore." So just decide, either we don't come anymore or we excise the lesion. Then we excised the lesion, and this was just a Spitz nevus. Although this is an exceptional evolution, right? So the probability that a lesion like this, looking like a Spitz, it's a melanoma, is just 0, okay? So they just resemble a little bit like melanoma. While after puberty, the probability that a spitzoid-looking lesion is a melanoma is increasing by the increasing age, okay? So it's on the average is 10 to 12%, okay? But look, after the age of 60, a lesion which is looking like a Spitz is not a Spitz, it's a melanoma. Yeah, can you imagine? See, this is extremely fascinating. So the probability before puberty is just 0, okay? So we don't care about Spitz nevi, but we, of course, we have to manage them. What I care a little bit more is congenital nevi. Why? Because if there is a precursor lesion of melanoma, this is congenital nevus, okay? That's the point. And of course, we know that the probability that the congenital nevus is developing into a melanoma is increasing by the increasing size of the lesion. Why? Because we have billions of melanocytes, and therefore one of them can transform, yeah, can become crazy. Okay, so this is easy to understand. Okay, so what to do in congenital nevi? Well, first of all, we have to understand that still the probability that the congenital nevus transform into melanoma is extremely low. Okay, overall is less than 1%. Yeah, less than 1%. It's 0.7. 0.7, okay? But of course, we know very well that we have three main types of congenital nevi, small congenital nevi, intermediate, and giant, okay? Small nevi, small congenital nevi do not have any risk, you know? It's like the acquired nevi, so no problem. But let's say between 1.5 centimeter and 20 centimeter, we already are in the intermediate size congenital nevi. And here, the risk is very variable. Nobody knows exactly. It could be 1%, it could be 0.1%. But let's say definitely it's not zero, okay? And I saw in my life at least I don't know, 20, 30, 40 intermediate size congenital nevi developing melanoma, okay? So in this particular group of patients, not during childhood, but afterwards, yeah? After 15, 16 years of age, we can suggest excision, okay? Because then the risk will become zero. It's not 1 out of 1,000 anymore, it's just 0. So if it's easy to remove, why not to remove it, you know? Instead of checking this patient every year forever, we can remove it. And we can remove it very easily because we can do it, we can do the serial excisions, you know? You remove one piece and then the other one and the other one and so on, okay? So it's not so difficult, but of course, I prefer to wait until the patient will like to do it, you know? Otherwise here, we have to do general anesthesia, and this is not really the case, okay? Of course, while waiting for the excision, we can check dermoscopically, and congenital nevi are easy to be checked. You know, usually they showed all the same structure, and whenever we see something which is wrong, it's easy to catch. For example, this one, this is a girl. This is a 14-year-old girl. The lesion is on the back, and this is the lesion present since birth. Yeah, and this is dermoscopically. There is something wrong in my view. I don't like too much this area here. Definitely, this area is in line with the congenital nevus, but this is not blue-white veil. You know, this is strange. Therefore, we excised the lesion, and this was a melanoma arising in a pre-existing congenital nevus. So it does exist, you know? Okay. So why not to remove them when the patient will like to do it? Okay. So this was concerning children. Basically, we don't care. We just care about Spitz nevi that we can follow, and we care about congenital nevi. Small congenital nevi, we don't care, but intermediate size congenital nevi, let's do a follow-up, and then maybe we excise them. Let's talk about, just for a moment, about this age group. Let's say, I mean, I'm 51, but I'm looking a little bit better than this one. Well, but after 50 years of age, things change. Yeah, we are not anymore young people, we are mature, we are more wise. Our skin is becoming a little bit more full of seborrheic keratosis, cherry angiomas, and on the opposite, our nevi, what's going on? Disappear, exactly. So in this age group, it's extremely easy, yeah? Because we have not too many nevi, we just have seborrheic keratosis, cherry angiomas, and dermal nevi, and sometimes melanoma. We don't have to forget that melanoma, although it's well known to be a tumor of young people, but the great majority of melanoma occur in patients over the age of 50. Okay, so we don't have to forget this. Yeah. And secondly, our job is easy because this is nevi, you know. So we are born without nevi, then nevi will develop, and then we die without nevi. Okay, so this is extremely good news. The point, what is the point in this age group? The point over the age of 50 is that since they have no nevi, they don't come to show us their skin lesions. Yeah? They come because they lose their hair. They come because they have rosacea. They come because they have dermatitis, whatever, you know. But they don't come to check their nevi because they don't have. So the problem is that sometimes we can miss them. We can miss the melanoma because we don't see it. Yeah? If we don't ask them to be naked, we don't see it. And also, sometimes when they are naked, we can miss it. Yeah? So, in this age group, the problem is not to be able to make the diagnosis. The problem is to see the lesion, you know? So we have to keep in mind this. Okay, but now let's go to this age group, which is the majority of our patients, okay? In this age group, we basically are doing most of our job. Look at this guy, how happy is he? Yeah? Of course, because there are many young ladies around him. Yeah, he's very happy, very happy. But dermoscopy makes our patients happy because we have to come closer, okay? So they will be happy. So what is the rules I follow in this age group? Basically 3 rules. First, the blink rule. What does it mean, the blink rule? I'm very fast with these patients, you know, because usually they have many nevi, so I have to be fast, okay? What kind of algorithm I use? My brain, you know? And as soon as we develop our ability to recognize benign or suspicious lesions, we will be able to make diagnosis in milliseconds, okay? Because our brain is pretty well trained to recognize morphologies, patterns. For example, how many milliseconds you need to recognize this face? What is your diagnosis? George Clooney, yeah, you're able to recognize him immediately, even though you never saw him personally, right? Yeah, just pictures, okay? So, milliseconds, this is the blink diagnosis, okay? Blink test. Who is this lady? Well, extremely difficult to say, because this is my sister, yeah? So you never saw her, and that's why you're not able to recognize them, to recognize her, okay? But if you see her twice, you will be able to recognize it forever, okay? So now this is the approach we use, okay? What's that? Benign, exactly, milliseconds. What's that? Melanoma, you don't need more. Do you need algorithms? Do you need analytic approach? You need scores? You need nothing. Come on. It's extremely easy. What's that? Benign, exactly. What's that? Malignant, of course. That's benign. Yeah, perfect. Okay, so that's basically what I use in my practice, okay? Nothing more. There are just a few lesions where I look at the lesion and I stay there, yeah? And I'm not able to decide. And then I start to ask stupid questions. How long do you have these lesions? Did you see some changes? You know, I'm just taking time to decide what is this lesion, okay? So in this case, this is a lesion where I have to think, you know, because I never saw something similar before, so my brain does not work, okay? So now I have to use my knowledge, okay? And I have to review all the criteria of melanoma, you know? So is there a typical network in this lesion? This is an example of a typical network. What does it mean? A typical network, you have more than one type of network within the lesion. Here we have very light network, here brown, and here intermediate, okay? So this is melanoma because of the network. Do I have regression features, okay? Melanophages plus white scar-like areas. Do I have this criterion, yes or no? Do I have, for example, blue-white veil, okay, which is a more compact blue-white color, usually corresponding to an elevated part of the lesion, you know, palpable area of the lesion. Do I have streaks at the periphery? Yeah, streaks in a melanoma because they are irregular, and streaks in a Spitz nevus, they are regularly distributed. Do I have them? Do I have dots and globules? Irregular, because they are located asymmetrically within the lesion or symmetrically within the lesion. Do I have them? Or do I have blotches, symmetric, asymmetric blotches, brown or black, dark brown or black structureless areas? Do I have vessels in this lesion? Okay, irregular vessels like on the left side, or typical comma vessels of a dermal nevus on the right side. Okay, so I have to review, I have to go analytical for the lesions I don't know what to say. And then sometimes also my analytical approach does not work. Okay, especially in patients with multiple nevi, because especially in patients with multiple nevi, if I go analytical or within the single lesions, everything is irregular, everything is ugly, and I have to excise everything. So I have to stop doing analytical, and I have just to compare. Okay, for example, this is a lesion, and of course we see just this lesion, and we cannot do all other than going analytical, okay? So is this a benign lesion, a suspicious lesion? Should we excise it? Suspicious, yeah. But yeah, of course, definitely this is not a typical nevus. But don't you think that if I compare with the rest of the lesions of this patient, it's much easier? Okay, because this is the lesion which is extremely different from all the rest of the lesions. Yeah, you see? They look pretty similar, while this is exactly completely different. Okay? So the analytical approach is also very important for patients with multiple nevi. So first, blink. Second, think if your brain does not work. And third, if you have a patient with multiple nevi, we have to compare. Okay? And now, just to conclude, I tell you what are the three most difficult melanomas to be diagnosed. In my view, one is exactly this one. Yeah? In patients with multiple nevi. Why? Because, of course, melanoma can be blinded, yeah? Masqueraded by the other nevi. Okay? In this case, we need to compare. We need to compare, we need to follow up this patient, and so we have a good strategy not to miss this kind of melanoma. We spoke already about facial melanoma, which is the second most difficult melanoma. Yeah, in this case, we know what to do now. We know that we have to compare, we have to see if there are benign features, and here we have clear-cut benign features, parallel lines, so this is benign, and here we don't have benign features and we have gray color. So now we have also a method for this kind of patient, and third, amelanotic melanoma. Yeah? Pink melanoma. This is also extremely difficult, but also in this case I have a rule. Yeah, what is the rule? That usually pink melanomas are nodular. Okay, so usually for nodular lesions I have to be very, very strict. Yeah, so I have to decide immediately if this is a benign lesion, I can leave it there, or I have to excise it if I'm not sure what it is. Okay, so this is the rule I apply. For example, is this what? Benign, cherry angioma. Are you sure? Yes, of course, so you can leave it there. Okay, so now this is another lesion. Could be pyogenic granuloma. Well, it could be benign, but when I say it's malignant, well, I don't know. I don't know if it's malignant. Am I sure about something? No, I'm not sure. I'm not sure, because this could be benign, But what kind of benign? I don't know. So I have to remove it. And this is 3.5 millimeter thick melanoma. Okay? So I know today that I have no chances to diagnose amelanotic melanoma. No chance. Okay? But I have a rule in my mind now how not to miss it. Okay? And to excise it. Okay? And the rule is, whenever I'm not sure what it is, in confronting with a nodular lesion, I have to excise it. Okay, so keep calm and use your dermatoscope.